I'll wait 1.5 more minutes. Okay, well, we will start this evening's webinar. Thank you so much, everyone, for logging in. I have received a few apologies from some people that couldn't make it tonight, but since everyone knows, it's no secret now that we record the webinars, everyone can access the replays on our YouTube channel. So I'll send the link out to that later anyway. I'll just begin again how I have begun the past 2 webinars with an acknowledgement of country, and then I'll go through what we're going to cover tonight, and then we'll get into it. So I begin today by acknowledging the traditional custodians of the land on which we meet today and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. So again, thank you so much everyone for being here. This is our last webinar of 2022. As you're aware, this year we've really tried to increase the opportunity for education for our people with MS. So we've done the monthly newsletters, which have linked you to other good places where you can find information. And we've also held these 3 live webinars. And so we will be sending an evaluation survey out a little bit later on, and we'd really appreciate everyone's feedback for that. So please keep an eye out for that and fill out the survey when you can. So tonight we're going to cover a few things. I'm going to be talking a little bit about mental health, and then Professor Hawke is going to be speaking about bladder and bowel incontinence and spasticity. Then he's giving a research update, and then we're going to have a time for question and answers. So if you have any burning questions, type them in the chat. I really want to encourage you, any questions, we'd love to spark discussion. So whatever, even if it's unrelated to what we're talking about tonight, if you have a question about MS that you really would like to know what Professor Hawke's take on it is, please type it into the chat and we'll get to that at the end of the night. Okay. All right, well, I will share my screen and we will begin our chat on mental health. So, here we are. All right, so mental health and MS. So you probably hear about mental health in a lot of spheres of your life. I think as we increase the conversation around what mental health is and how to combat mental illnesses, there's a lot of normalizing of what's going on. And it's really important that we do talk about MS. We do talk about mental health with people that have MS, because around 50% of people with MS will experience depression, and that is 2 to 5 times higher than the general population. And the thing with that is, with MS, you know this better than I do, your common symptoms can include fatigue, pain, physical disability, muscular weakness, spasms, cognitive dysfunction. The list goes on. You could tell me all about it. But MS also has the potential to cause life disruptions with changes in your work life and your personal and social life. And so that's why it's really important that we have an awareness of what good mental health is, especially when we have MS. And the thing with this is that it's complex. So depression is not always a straightforward diagnosis, and especially in someone with MS. For the general population, fatigue is one of the symptoms, but this can be complicated when if you have MS, you already experience fatigue as part of your MS. So there's other mood disorders such as adjustment disorder And adjustment disorder is a reaction to a new diagnosis. And so you might relate to this, where when you were first diagnosed with MS, the feelings that you felt with having a life-altering diagnosis, and what did that now mean, these can present like depression. You can feel low in mood, you can feel flat, you can feel like you're not having interest in many things. And so this is adjustment disorder. And then there's the psychological toll of living with MS. So there's the day-to-day stresses of what you go through. You know, living with a chronic neurological disease has plenty of challenges, and the limitations can actually take that psychological toll on you. And then there's also the depressive disorder, which is due to a medical condition. So this is where MS actually causes the symptoms of depression via inflammation or degeneration of the brain matter. And so this is where the depression is literally a result of what MS is doing in your body. So that's why it's complex when we think about what mental health means for someone who has MS. So of course it's a huge field, but I wanted to talk about a little aspect of it. So there was a really big study done on people with MS and coping, with a focus on coping strategies. And so there's a whole list of different coping strategies. And what they found was when in people with MS, when they accepted and acknowledged their diagnosis, they actually experienced less severity and frequency of stress. And so this meant that they had a better quality of life because they were able to cope with the changes better. They found, though, one of the ways of coping is venting your emotions. So venting negative emotion. And I mean, I'm guilty of venting negative emotion. But as a coping strategy for people with MS, they found that people that did that or were in denial about their diagnosis or became mentally disengaged. So this is where you try to avoid the fact that you have MS. So maybe you don't want to do treatment right away. Maybe you want to try, I'm not saying that this is an exact example, but these are some ways that people might disengage from what is happening. So this study found that people who coped either venting, were in denial, or tried to disengage or escape the reality, they actually experienced significantly more stress. I thought that was really interesting because if you think of a stressful situation that you had today, if you think about how did you cope with that, you know, did you accept it? Did you think, oh, that it is what it is? Or did you avoid it? Did you binge eat? Did you look to something else to escape the reality? So it's really quite interesting. Conversely, the coping strategies that actually had benefits in people with MS are these sorts of coping strategies here. So if we go through them, acceptance, that's when you're accepting of the situation. For someone with MS, you know, that's an acceptance of what the diagnosis is. Growth, they call it growth, but growth is basically when you find positives in a stressful situation. So when you're faced with a challenging situation, are you able to see the positives in what's going on? For example, my 5-year-old son this evening, he said, I had a bad day today. And then I said, why did you say that? Didn't you have a cupcake, play outside, do all of these fun things? And he said, yes, but it's a bad day. But this is part of that trying to find positives in a stressful situation. When we break down what a situation is, finding the positives actually helps you grow. And another coping strategy is the active coping strategy. So performing specific actions to deal with the situation. If you apply this to the context of MS, you know, maybe it's that Professor Hawke has said, okay, we're going to start you on this medication. And so you say, yeah, what else do I need to do? And maybe he says, maybe you need to look at eating healthy, trying to lose some weight. And so performing specific actions to deal with the situation is a way of coping, and it's linked to quite positive outcomes. Planning, strategizing how to deal with a stressful situation. I think I often do that with you guys when when we talk, after diagnosis, when we talk about what's the next step. We're gonna look at the information about a medication. What's the next step? But you can apply that in any situation of your life, and that's a coping strategy. And then there's two more here: restraint, so not responding to stress in a reactive way. If something big challenges you, instead of responding straight away of what you actually feel, instead holding that back, that's a way of coping, that restraint. And being able to take a breath, maybe thinking about things before you let everyone know what you really think. And then social support. This is a really good one. Social support is where you seek support from others to solve the problem. And I think that's really important when it comes to dealing with your MS. You need your family around you. You need a good health team around you. You need friends that can understand what you're going through. And so seeking support from others to solve the problem. And I know that, especially, I think a lot of you, probably every one of you, are very independent thinkers. You're very capable people. And so sometimes it can be hard to ask for help, but asking for help can actually help you deal with living with MS. And so just to touch on, to go back to the depression and the incidence in MS, these are two questions that you can ask of yourself that might help highlight that you may be feeling symptoms of depression. So have you felt low in mood or feeling flat or hopeless in the past 2 weeks? And have you had little interest or pleasure in doing things? So things that you usually find joy in, has it been different in the past 2 weeks? If you would answer yes to these questions, I would definitely recommend seeing someone else for help. What would be the next step? The next step is seeing a GP. They're probably a great first port of call, and the GP can then recommend you onto different pathways. So counselling, it can be hard to find a counsellor. There are many digital options available. If you need help to find a counsellor, please let me know. But it's easy as well for us to, dismiss counselling as, me just letting out my negative feelings. But there's a lot of strategies that counsellors or psychologists can use to help you reframe what you're going through. And there's also medication, which can really help you overcome these feelings of depression. And as we touched on a little bit earlier, working on ways to accept your stressful situation, seeking help from people around you, and finding active strategies to identify your personal goals. So what is it? I think living with MS, you have to adjust what your own expectations of yourself are. So what are they? And you can definitely still have personal goals. And what are some things and activities that you can do to help you stay motivated? If you do have any questions about that, please leave them in the chat, or if you'd like to chat with me about anything that maybe started a thought, please email me. But that's all I have to say about that. We will now go on to the section from Professor Hawke about bladder and bowel incontinence.
Thanks, Karina. Can you hear me? Okay. So let's go to the next slide. Okay. Now, some people wanted a little bit of information about bladder and bowel dysfunction and spasticity, and this here is an anatomical diagram of the spinal cord and the bladder. Now, a lot of this activity that really has to occur every day of your life is under a special type of the nervous system called the autonomic nervous system. So when we think of, say, moving our hand, we actually generate the motor thought in our motor part of the brain. It travels down the spinal cord, gets out into through nerves into the muscles of contracting the hand. That is not the same part of the nervous system as the autonomic nervous system. So I like to think of the autonomic nervous system as the automatic nervous system. That is the part of the nervous system that we don't necessarily control or need to control. It just works away without our thought processes. And so that part of the nervous system controls, for instance, our heart rate, our blood pressure. It controls the tone in blood vessels, say in our legs. So every time we stand up, we have contraction of the blood vessels, particularly the veins, and that stops blood pooling. Our heart rate goes up. And so that allows the heart to continue pumping out blood. Now, that's one example of the autonomic or the automatic nervous system. There are quite a lot of other ones. There's sweating. And here we're particularly talking about the bladder and the bowel. So what basically happens with the bladder is you can see on the top there, these little green dots and the title stretch receptors. So what happens is that urine is filtered out of the blood continuously in the kidneys. And there's a whole range of the autonomic nervous system and hormonal control of how much of the urine is filtered out, whether you concentrate it or not. Very, very complex. Control of blood pressure, all these things actually are in the kidney itself. But then the tubes out of the kidney called the ureters, they then come down into the bladder. So there's a whole lot of stuff going on before that happens. But then the bladder is filled up by urine, and it gradually gets bigger the more urine that comes down. So these receptors, these stretch receptors, start firing off slowly, and then as more and more urine gets into the bladder gets bigger in size, and then you start to get these sort of signals to your brain that your bladder is starting to get full. Now, normally we don't get those, but then when the bladder reaches a certain size, those signals that your bladder is full gradually become more and more prominent. And then we have time usually to get to the loo and to open our bladder. And what happens there is we relax. There's an external sphincter right down the bottom, and that's the one that's sort of under voluntary control, but we're able to contract. And then that relaxes. And then another reflex, which is part of the autonomic nervous system, comes and controls the muscle in the wall of the bladder, and that contracts the bladder and usually empties it. And then we go through the same cycle again. Urine continues to flow down the kidney, out of the kidneys almost continuously. It gradually builds up again. The bladder gets bigger. You get these signals, and then eventually you decide you want to go, and it contracts, and you release the external sphincter that allows you to hold your urine in, and then the autonomic system, different part of the autonomic system, contracts the bladder muscle. So that's under autonomic control, the automatic nervous system. And so this continues. Now, what happens when you have problems with the spinal cord? We have these descending mechanisms that sort of dampen down that reflex of distension of the bladder leading to contraction. So what often will happen is that the bladder fills up to a greater amount than would normally happen. And then we're not able to suppress that reflex. So we don't get that time to let the bladder fill up and allow us to get to the bathroom. So this sort of becomes out of control. It becomes overactive. And so that's often the first bladder issue that one sees with MS, and it's an impairment of the descending inhibitory control of this autonomic nervous system. So that, and what that often means early on is that a small amount of urine will actually trigger that response. We can't control it. So, and then eventually more and more urine gets in the bladder before you start to get those contractive signals. And the bladder then doesn't contract as well, because if the bladder gets too big, the muscle won't contract. So after you do pass urine, you don't release all of it. So on the one hand, we have this loss of the inhibition, and that causes urgency and frequency. So you get the urge to go and you have to go. You get frequency because your bladder isn't able to accommodate as much of the urine that's coming out of the kidneys before it automatically contracts. And then eventually you end up with a bladder that's quite big and floppy, and you don't release all the bladder, and sometimes you end up with incontinence. You can obviously be incontinent if you haven't got time to get to the bladder if you have urinary urgency. So that's what happens. Usually what happens, the frequency goes up, the urgency is a problem, the bladder's contracting well, you're still getting rid of your urine. And over time, that ability to get rid of the urine becomes less effective. So how do we normally manage these things? Well, we have medication which actually affects the autonomic nervous system. Oxybutynin is one that we tend to use to start with, and that slows down this reflex contraction of the bladder, and that's quite helpful for bladder urgency and frequency. And but then over time, if the bladder is pooling and not being expelled, sorry, if the urine is pooling and not being expelled because the bladder is not working as well, then those drugs don't work. And in fact, they can actually make things worse. So when you have an increased amount of urine after the contraction, and we call that an increased residual volume, residual because you've actually voided, and we've actually measured the amount of urine left in your bladder with an ultrasound. So that's why ultrasounds are really useful here. When that amount of urine gets significant, over 100, 200 mils, we know then that is going to predispose people to infection. And then eventually we need to teach people to catheterize. And that's what self-intermittent catheterization is. And then people pop a catheter in, several times a day. It's not as easy in men compared to women, but the idea is that we don't want to have residual amounts of urine because that can predispose you to infection. If you get infection in the bladder, that can travel up the tubes to the kidneys, and that can damage your kidneys. So eventually, people, just for convenience, might have a catheter put in. And what we tend to do these days is put a suprapubic catheter in. So that's a little plastic tube that goes into the bladder. And that bypasses the need to use the normal mechanisms for getting rid of urine out of your bladder. So it's very common to have bladder issues. It's more common if you have lesions in your spinal cord. Does the medication that we're treating your MS with to stop the immune system being overactive work? Sometimes it does if you've got inflammation and the inflammation settles down. Sometimes bladder function can improve, but generally not, and we have to use these other treatments, these symptomatic treatments. The bowel is rather similar. There's similar sort of reflex control of your bowel function by the autonomic nervous system. And if people have urgency of opening their bowels, which can be very, very difficult. So you go on a trip, say over the mountains, you have to, as soon as you get that urge to go, you have to rush. Well, the same drugs like the anticholinergics can be helpful. And then we also have another class of drugs, which unfortunately are not on the PBS, but I think some people will be on these. These are drugs which actually act on central control in the brainstem of the descending reflexes. So there's a whole lot of, there's brainstem centers which control this reflex arc, which comes out of the spinal cord. And they can be influenced by drugs such as Betmega or mirabegron. So that's bladder and bowel issues. In terms of spasticity, it's the same sort of concept that if you have problems or demyelination affecting the descending motor pathways, there's reflexes which actually are in the voluntary part of the immune system, the nervous system, not the automatic part of the nervous system. Obviously, when you think of moving your hand, the impulses go down the special motor tracts into the motor nerves, out into interfacing with the muscles for contracting your hand or leg or foot. And if there's been damage to some of the descending motor pathways, some of these reflexes become hypersensitive and you end up with muscles contracting continuously. And that's what rigidity is and spasticity. So when the voluntary control of muscles becomes less effective, the descent, because of the lack of descending wires, if you like, controlling motor nerve cells in the bottom of the spinal cord, which go out into the nerves, the muscles become overactive and get rigid, and that's what spasticity is. And we do have drugs which can reduce spasticity, and they work on the central nervous system. Some of the neurotransmitters particularly seem to be important in spasticity. So these drugs like baclofen, they work by, in part, sort of reducing that hypersensitivity going down the motor nerves, but they also tend to weaken the muscles too. So that's one of the limiting factors with these drugs, that they can, if you get too much of them, they can actually make you weaker than you were, and you wouldn't have the increased muscle tone or spasticity unless there was a problem with the motor function. So that's a limitation. Other limitations are that they can make you tired and sleepy, drowsy if you give too much of them. So one thing that very occasionally we do, if people have a lot of spasticity, is actually to put pumps in into the spinal cord, which pump out the drugs, particularly baclofen, directly into where the motor pathways are. What we tend to do, though, before that these days is use medication, particularly Botox, that you may have heard of, which is used very commonly cosmetically. So if you've got a few wrinkles, you get the doctor to stick a few needles into the muscles, and if you can relax the muscles on your face, you can get rid of the wrinkles. And Botox actually is quite useful for a number of things I didn't mention, but also Botox can be used into the bladder, because that can, within the bladder, reduce the hypercontractility of the bladder muscle. But with the motor system, if there are particular muscles, say in your legs, which are causing difficulty for you opening your legs, or you get spasms, then we can use botulinum toxin into the muscles, and that weakens them, and it's not permanent. So that's the good thing about it. So we use quite a lot of botulinum toxin for different types of overactivity of muscular contraction, and that can occur in your neck, but particularly with MS, in your legs. So if you're getting adductor spasm, so your knees are constantly being pulled together, we can put both botulinum toxin into the muscles, temporarily using Botox And it's not only for MS, but any condition that affects motor pathways, so such as stroke, the same thing can happen. And it has to be done every 3 months. And that's, in a sense, a good thing because it wears off. So, there's nothing sort of permanent. Okay, so I think that's probably all I will speak about with bladder function, bowel function. I'm sure you'll have some questions.
I have a quick question. If someone was thinking maybe that they might want Botox for their function, if they've tried medication, who would they speak to?
Well, I don't do Botox, but Dr. Blackwood, my colleague, she's a whiz at doing Botox for all different conditions. One issue is the cost, because only some conditions the Botox is supported by the PBS, but I'm pretty sure now for spasticity in larger muscles, because that was the problem. If you have a large muscle that needs Botox, you've got to put quite a lot of Botox into it because it only works locally by partially paralyzing that particular muscle, the one that's overactive. So say your thigh muscles are overactive, your hamstrings, you're going to be using a lot of Botox. But I think now the government does support the use of Botox for spasticity. So Dr. Blackwood is the one. So if you probably should speak, if you think that might be useful, speak to your neurologist. And it's not only Dr. Blackwood, but in our practice, Professor Davies also does it. But it can be quite useful for spasms. We often use baclofen first because it's easier to use, and it's a tablet. But there are other ways of dealing with it.
Yeah, great. Thank you.
So should we move on to the next section?
Yeah, definitely. I don't think any.
And we'll have plenty of time for people to ask questions.
Yeah.
Okay, so I'm talking next, aren't I?
Yes, so now you're going to be giving an update on the research.
Okay, so you get me again. Now, look, I wanted to talk about vitamin D because there've been two very important papers that have only been published. Haven't even been published. They've been spoken about at ECTRIMS, which is currently on as we speak in Amsterdam. So ECTRIMS is the European Committee on MS research, and it's the biggest MS conference in the world, and it's on actually at the moment. And I just wanted to talk a little bit about some of the very recent results on vitamin D. Now, what about vitamin D? Now, the first thing we know about with MS, and a lot of this work was done by Simon Hammond, my colleague in Orange, and he did his PhD on this years and years ago with Professor McLeod, James McLeod, who sadly died recently, aged 90. But Professor McLeod was one of the great neurologists in Australia, and he was interested in MS particularly, but also in peripheral nerve disorders, and he was based at the University of Sydney. And Simon Hammond, who came out from the UK, did his PhD, his doctorate, working on the epidemiology of MS, how common is MS in Australia. And he did various studies with colleagues. And this was some of the best data and establishing what we call the latitude gradient of the incidence or how common MS is in populations. And in Australia, you can basically see pretty clearly that MS is far less common the further north you go, and far more common the further south you go. So these studies were done, Simon Hammond did studies in Perth and Newcastle and in Hobart, but other studies have been done in Brisbane as well, and some people have done studies in Darwin too. And what that has done is establish that it is clear that the further away from the equator you go, the more common MS is. And this is the same thing goes for New Zealand. And my colleague Bruce Taylor, who's now in Tasmania in Hobart, he did these studies some years ago. But it also extensive studies have been done in the UK. And the most common place in the UK where you have MS is in the Northern Islands, off the northern tip of Scotland, the Orkney Islands, and in the southern part of England, the prevalence or how common MS is much less. So you get this sort of gradient, even in a small country like the UK, but it's quite marked in Australia. And the other thing that Simon Hammond did, just to say in passing, that when he looked at the migration of people to Australia, he found that if you migrated before the age of 15, you assumed if you like, the natural prevalence of MS in the place to where you went. So say you migrated from Glasgow or Edinburgh in Scotland, and you went to Darwin. If you went there before the age of 15, your risk of developing MS would be no greater than someone living in Darwin. But if you migrated after the age of 15, you would always keep that, if you like, increased risk of developing MS. And, why is this the case? So the obvious thing, which has led to, I think, one of the reasons why vitamin D is very common is used very widely, is because the idea is that if you're living in the equator, you're going to have a lot more exposure to vitamin D than if to sunlight, which of course you need sunlight to make vitamin D naturally. So vitamin D, which is very important for bone health, is made in the skin because of sunlight. And if you live in a cold climate, you're going to be inside wearing a lot of clothes, so you won't go out. And so vitamin D has sort of been thought to be the link. And there have been some other factors where vitamin D has been has been linked to MS, and that comes from genetic studies. So these genome-wide association studies where you take a very large number of people who have MS compared to people who don't have MS, and you look at their genetic makeup, and you can actually use markers of marker genes to look at which part of your human genome is different between people who have MS and people who don't. And probably the greatest differences are occurring in genes which are important for immune recognition, for T cells and B cells. So these immune response genes, that's probably the greatest difference between people genetically. We're talking about genetically how you're made up. But there was also one vitamin D gene in one study that seem to be different in people with MS. But these things are never hard and fast. So you might find, if you like, we call these polymorphisms. So these are normal differences in the gene between a group of people with MS and a healthy control group. There might be, say, 40% in the healthy control group and 60% in people with MS. So it's none of these genes sort of really do, differentiate, if you like, people who have MS and people who don't. So it's sort of like a susceptibility factor. So one thing we have to think of, though, is that what has become abundantly clear in recent years is that the sunlight does a whole heap of stuff to your immune system, which has nothing to do with vitamin D. So if you are exposed to sun, it has big effects on B cells in the skin, in memory B, the development of memory B cells. And one of my colleagues, Scott Byrne, who's one of our collaborators, he's an immunologist who's done a lot of work in dermatology, and he's done a lot of work on B cells and the effect of sunlight. And yeah, vitamin D is just one factor in what happens to the sun. So a small amount of sun is potentially quite useful. And so much so they've actually they were doing a study in Perth looking at small doses of ultraviolet light. Now, I don't want to encourage people to get ultraviolet light and irradiate themselves, but a little bit of sun is probably a good thing, not too much, but it's in terms of the effect on MS, it's probably not mediated through vitamin D, but people are taking vitamin D. So there's been a big unknown about, can we prove that vitamin D actually has an influence on your MS? And this is in people who have early MS. So let's go to the next one. And when people have early MS, we call this the clinically isolated syndrome. And so people might have they haven't met the criteria for developing MS, what we call the McDonald criteria, from Ian McDonald, who was a New Zealander from Otago, lovely neurologist who worked in London. I knew very well. And he developed the criteria with experts around the world to allow a diagnosis of MS, and we're able to do this earlier and earlier. But there was a study set up a few years ago and funded by MS Research Australia called the PREVANT study in people with this clinically isolated syndrome. And they randomized people into different doses of vitamin D, placebo, and they looked to see whether or not various doses of vitamin D or not prevented a diagnosis of MS. So often people will have a symptom and have some inflammation, but it needs another bout of the immune system attacking your central nervous system to make a definite diagnosis. So what that meant, that if people were prone to develop MS when their immune system is attacking the central nervous system, if you treated people in the very early stages with vitamin D, could you prevent the development of MS? Quite a powerful way of determining whether a drug works. And this has been done with a number of different drugs, interferons, Copaxone, various other drugs, showing that they actually work in quite a short study. Another study in people with relapsing remitting MS who were already on Copaxone, one of the disease-modifying therapies, they were randomized or not to receive 2 different doses of vitamin D. And it was pretty clear looking at people over 48 months that there was no effect in stopping relapses or new MRI lesions forming in the brains of people. So 2 studies basically coming out with the same result, that vitamin D really doesn't have any effect on preventing inflammation in MS. So we can't, unfortunately, now we can be certain that we can't rely on it to do the effect of dampening down the immune system and stopping new areas of inflammation. It's obviously important for bone health, and there's a lot of studies that come out with vitamin D on other factors, but in terms specifically of MS and its MS activity, we're not able to show that it has a positive effect. So I think that was interesting. That this has only just been released, in the last 24, 48 hours. So I think this question has now been answered. It's disappointing for the people who are involved with it. I don't know, some people in our area may have been involved in it, in this study, in the PREVANT study, but yeah, it's unfortunately turned out to be a negative study. Okay, so I think probably I've said enough. So if you've got any questions or if you want to bring up anything else, Karina,
Yeah.
now's your chance.
Well, so we've got a few comments. So Doug Kinleyside said, I've been taking vitamin D supplements of 50,000 units per week for over 10 years, but recently the GP doesn't agree that he needs to monitor his vitamin D levels each year. Is he overdoing his vitamin D supplements?
That's mega doses of vitamin D. There's no doubt that it would be a bit of a waste of time measuring your vitamin D levels because they'd be through the roof. There's some evidence to suggest that in experimental models of MS in mice and rats, that high doses of vitamin D can dampen down the immune system. But it looks pretty clear that, and I should say that this Australian study was vitamin D alone. It wasn't, there was no other disease modifying therapy involved. So that's pure vitamin D, whereas the US study, people were already on Copaxone. But I don't think I personally would take the view that, there's no good evidence now that suggests vitamin D is doing anything in MS. So I'm not sure whether 50,000 units is going to be any better, but if, I'm not aware of any evidence that suggests that 5 or 10,000 units is going to be more effective, or less effective than 50,000 units. So yeah, I'm not really sure what to suggest, but I would take home the view that from these two studies that there's not really evidence that suggests that vitamin D does anything. So, should you be on it, I think is the question.
Yeah.
Difficult if you've been on it for 10 years. But many people have been on vitamin D for a long time. But I think the evidence now is coming out, today from these two studies that it probably doesn't make much difference. Certainly with the proviso that we're talking here about relapsing remitting MS. So we're talking about, and there hasn't been a study looking at vitamin D in people with progressive MS. But I would have thought that if we don't see anything in preventing new lesions in MS when in relapsing remitting MS, is it likely to have an effect in progressive MS? I'm not sure.
Yeah, it's very interesting because I think it was, seemed like the common advice was to start taking vitamin D for potential effects. There's another question. So if someone doesn't have any lesions on their spinal cord, is there, I don't know what's happening. Sorry, don't know how that stopped. I don't know how to. Oh.
Is that your Mac?
No, that's not my screen. I'm not sure how.
Oh, we're viewing Susan's screen.
Susan.
Yeah, we've got someone else in.
Let's see. We'll just stop that. Sorry, Susan. So if someone doesn't have any lesions on their spinal cord, can they still experiencing bladder or bowel urgency?
I think yes. I don't think that's common, but I think that's possible because we don't see all the lesions on MRI, but also over time, if some of these descending pathways, which are coming down from the brain, are affected, or in the brainstem are affected by demyelination, then that can affect bladder function. So there are certainly descending pathways in the spinal cord coming from the autonomic nervous system centers in the base of the brain stem, that if they are affected by the MS, that they will influence the control of bladder function. So yes, you don't have to have lesions in the spinal cord to get bladder problems.
Okay, yeah. Were there any other questions? Now is the time.
I think we can look forward to hearing more exciting stuff coming out of the ECTRIMS meeting. You know, that's the world, as I said, that's the world's main MS, and there's a lot of interesting stuff coming out about Epstein-Barr virus and so forth. So there's another question.
Yeah, there's another question. Can shooting pain down one leg be caused from the bladder or lesion in a lower spine?
It can certainly be caused by a lesion in the lower spine, shooting pain down one leg. But can a bladder problem cause pain shooting down the leg? It's hard to imagine how. You might have a lesion which causes bladder problems and a problem with the leg in the spinal cord, for instance. You might have a disc prolapse. You know, that's, so we're talking about the lumbar spine. Now, the spinal cord doesn't, in an adult, only stops at the upper lumbar region, because when you're a child, it goes right to the bottom of the spinal canal. But when you grow in adolescence and get taller, your spinal cord doesn't get longer, and only the nerve roots are down in the lumbar spine. So if you have a disc prolapse in the lumbar spine, which wouldn't be anything to do with MS, because MS doesn't affect anything below the spinal cord in terms of where lesions are, that if you had a disc prolapse, particularly a large disc prolapse, you can have bladder symptoms, because that interferes with the nerves directly, which are going to control bladder function, those autonomic nerves. And you might have pressure on another nerve, which might cause sciatica, so-called. So say if you have a large disc prolapse right at the bottom at L5S1, you can get bladder problems and you can get pain going down the leg. So that would be the usual link, I think, either due to a disc prolapse, which is not necessarily to do with MS, or in the spinal cord higher up, you might have a problem affecting bladder function and motor function. But of course, with MS, you know, you can have a lesion in the brain or in the motor pathways in the brain, which is causing a problem with the leg, and also pain can be caused if the sensory pathways are affected by the MS higher up. So it might not just be all in the one thing. So I don't think the bladder itself. So, I mean, theoretically, you can have things like endometriosis in a woman, which can affect the bladder and can also affect the nerves. You can have endometriosis, which is basically ectopic uterine tissue, which can be sprinkled throughout the pelvis, that can be adjacent to the sciatic nerve and can affect the bladder as well. So that could be sort of one link. But generally speaking, as far as MS is concerned, you wouldn't expect that to happen, a bladder problem to cause pain down the leg. So I guess you better talk about that with your doctor.
Hello, can you hear me?
Yeah.
My name is Eilena, and talking about vitamin D, Professor Hawke, I think I have explained to you how it affects me. If I have a really good dose of the sun, I used to be able to, I'd be out in the garden and get a really good dose of the sun, and I could go in and clean my house right through. I had energy for about an hour after it, you know, and then I think I told you once I was on a cruise and I was right up at the point of the top of the ship, you know, and a lady was lying there. She said, "I'll sit and have a talk." And I really became very sunburned. But when I got up and walked away, it was like I had nothing wrong with me. And I don't know why this is. But if I have a really good dose of the sun, it really, you know, I'm really good for about 2 hours after it. And I often wonder why. I think I explained to you about that, and they had an article about me. I've had in the In Touch magazine, and said I'd had MS for 24 years. Well, I haven't. I'm 76 in December, and I've had it since I was 15, and I'm still walking. So I've kept myself very fit with lots and lots of exercise. I think I explained that to you. And one of the best things I have ever done was have the supracatheter put in. I'm getting off the subject now of vitamin D, but just to all of you people who have bladder problems, everywhere I went, I was looking for toilets all the time, petrified I was going to have an accident. And I had the catheter put in, and it's the best thing I have ever done. And I don't know if you're interested in knowing how I look after it, but I cut the top side out of a disinfectant bottle, and I sit with that between my knees, and the catheter's on the little switch is on a tube coming out of they put a hole in your tummy for the catheter, and it's changed every 6 weeks by the nurses that the district area nursing service. They come and they change the catheter. But if you're very, very particular about hygiene with it, and you make sure through the day, I just empty it every 2 hours, and you never you don't have bladder problems and things like that.
Thanks very much, Eileen, for sharing that with us. I mean, I was going to ask you about the vitamin D, whether would you get the same effect if you took a tablet of vitamin D, or is it the sun? No. So it's really
it is the sun.
Yeah, no, that's what I was saying, that, you know, we've got the latitude gradient, and it's probably, the sun's important, and but it's probably not actually through vitamin D. It's probably through all the other things that the sun does to your immune system, and it's a very complex story.
Yes.
So it's not just vitamin D. So it was the sun itself. Yeah, that's interesting. That's interesting.
Well, just after the war, the Faroe Islands, above the highest islands, you know, above England, they sent soldiers up there. They thought the Germans might come around the top of England, and when they left after the war, they'd never had one person diagnosed had MS, but then there was quite a lot, and they just wondered if that was carried up there by the soldiers. Or
yeah, we would say now that it looks like it was glandular fever, which it was always thought to be an infection in the Faroe Islands, and it looks like now, with the recent evidence coming out with vitamin D, with Epstein-Barr virus, the glandular fever virus, that is probably that the Faroe Islanders had never been exposed to glandular fever, but the soldiers, as you say, brought it with them. Fascinating, really.
Well, thank you so much, everyone. That's all we have time for. Thank you again for joining us this evening, and please make sure that you look out for our feedback survey, and of course you can always email if you have any other questions. Thanks, everyone. See you later.
Thank you. Bye.